Hello and welcome. My name is Dr. Karolinne Rocha. I'm a cornea, cataract, and refractive specialist, director of cornea here at Medical University of South Carolina. And I'm here today with a dear friend, Dr. Sumit Garg. Dr. Garg is a professor of ophthalmology and vice chair at UC Irvine. So, Dr. Garg, it's a pleasure to have you here today.
Thank you.
And today we're going to discuss basically how to optimize IOL selection for patients requiring cataract surgery. And again, we're going to also talk about some complex cases. So what must we include in the pre-op assessment of patients scheduled for cataract surgery? So first, really important that past medical history, past ocular history, if the patients had any surgery, any dry eye symptoms, or maybe that patient had a pterygium surgery or any issues, right? And current symptoms, or the patients experience any visual loss or issues with daily activities. And again, anyone assess at that time visual goals, patients' expectations. For testing, I can share what I do in my clinical practice. Definitely corneal topography and tomography is very important, especially when managing astigmatism. You want to rule out, regular versus irregular astigmatism, optical biometry. And then you need to have a plan to address, especially astigmatism correction. We're going to talk about that more. And I always get a macular OCT for every single patient, because especially a patient with a dense cataract, sometimes you don't have a really good view of the macula, and you may miss an extrafoveal ERM or subfoveal drusen or anything that can compromise visual outcomes after cataract surgery. On the eye exam, we want to make sure you do that complete eye exam, starting with eyelids. Again, we're looking for common things, blepharitis, meibomian gland dysfunction, the tear film, and you want to look at the cornea. Do you see epithelial basement membrane dystrophy or Salzmann nodules, or even, dry eyes, PE. So those are things that we see on a daily basis. Cornea guttata, for example, right? So those are so important things when you're planning and selecting an IOL for the patients. And the iris defects, a history of trauma. But again, it's so important to make the diagnosis prior to surgery. And I like to teach anything, it's important to make the diagnosis prior to surgery. Anything you tell the patients after surgery is usually your fault. So this is your chance to do a really good preoperative testing and eye exam. And then you will talk to the patients, about surgery, what to expect, and your post-op regimen, again, it can be dropless, or if you're using drops after surgery, and just your flow and exactly what to expect during surgery, risks and benefits. And then your informed consent, right? So if you have a recommendation of a specific lens type, is really, again, important to tell your patients what to expect after surgery. And you want to check all the boxes there. Professor Garg, so thank you again for being here today. So, but what do you do in your practice? Can you share with us your pre-op evaluation?
Yeah, thanks, Karolinne, for having me. So, when we look at our preoperative patients, I think the history is very important. When you look at the preoperative assessment, the questions that I ask my patients are sort of, what are their goals for their surgery? What are they trying to achieve? Have they had previous surgery? Sometimes they don't remember that they've had previous surgery or trauma. Knowing what their historic refraction is, I think that's a fine point that often gets overlooked. Are they starting out myopic? Are they starting out hyperopic? Do they have astigmatism? All these things are very important in choosing and counseling your patient. Have they worn contact lenses? Did they wear them recently? Do they wear hard contact lenses, soft contact lenses? All these impact our ability to get proper measurements, which then impacts how we can treat these patients and how we can really try to nail our targets. And then with respect to what do they want out of the surgery, how tolerant are they to dysphotopsia? How dependent or independent do they want to be from glasses? I tell every patient that there's no free lunch here. So every choice we make, there's some compromise, and we'll have to figure out what will give you the most optimal outcome with the most acceptable sort of side effects or compromises.
Those are great points. Thank you. Question 2. So we have a 65-year-old female patient comes in with nighttime glare and halos, and she is willing to wear reading glasses some at a time. So what IOL would you consider for this patient?
Yeah, this is a patient I would really want to talk to a little bit more about what her goals are. I think it's important for patients to realize that preoperative glare is different than postoperative glare. Oftentimes, preoperative glare is, going to be impacted by the quality of the cataract, the location of the cataract, and postoperative glare is, in most cases, from a diffractive IOL. That being said, a non-diffractive EDOF lens or some of these enhanced monofocal lenses would work really well for this patient. I think in my hands, an enhanced monofocal lens, I usually target distance in their dominant eye and a little myopic offset in their non-dominant eye. And with that, you get you actually get really good distance vision and some usable intermediate and near. And I talk to my patients about what I'm doing. I think all too often we sort of tell the patient that, hey, leave it to us. And then they have to figure it out afterwards what we've done. I'm very forward with telling them, hey, in your dominant eye, I'm going to try to go for distance. In your non-dominant eye, I'm going to go a little bit off. When you compare the two eyes, they may be a little different, but everyone's eyes are a little bit different and your brain will get used to it. And with that, I give you the best chance at getting some range of vision without inducing any dysphotopsia. On the other hand, if she wasn't so against dysphotopsia and understood that perhaps the dysphotopsia profile after surgery would be different, then perhaps we could consider a diffractive IOL or a diffractive EDOF lens.
Fantastic. Thank you so much. Again, so important, to listen to your patients so you can match the technology to the patient's needs. What techniques are available to detect conditions such as dry eye disease or epithelial basement membrane dystrophy? So what again do you do to optimize the ocular surface prior to cataract surgery?
Yeah, another great question. So this is really important. If you're going to do refractive cataract surgery, you have to look at the ocular surface and you have to embrace treating the ocular surface. In many of our practices, the first time we see the patient is actually not the time we're signing up the patient for surgery, but we're seeing them and then we'll see them back in a year because their cataract's not really ready yet. I use pretty much every opportunity I have to see the patient to talk about the importance of the ocular surface. We know that the cornea and where the tear film is responsible for 2/3 of the focusing power of the eye. And if there's any irregularity there, no matter how special a lens or standard lens you put in their eye, still the majority of focusing happens at the ocular surface. So really important to look at the ocular surface. When you use your slit lamp and you look at the tear film, you want to look at not only for SPK, but you want to look at the regularity of the tear film. You want to look at how rapid the tear breakup time is. You want to look at the meibomian glands. The ASCRS Cornea Clinical Committee a few years ago put out their algorithm with the pull, push, lift, look sort of way of looking at the ocular surface. I think that's really important. The other thing that's really important, I think that's helpful, is using things like tomography or topography, and not just looking at the numbers that those tests generate, but looking at the patterns and looking to see how regular the actual patterns are. I think that's very, very important. And really, it can be a nice educational tool to help show your patient, hey, look at this. You see this bow tie. This is why I'm recommending a toric lens. You see how this looks like it's irregular over here. This is why you need to treat your dryness, and we can reevaluate that prior to making a final lens choice for you. So to me, ocular surface optimization is really, really key, and it's important to embrace it.
Wonderful. Thank you so much. That was very helpful. How do we optimize biometry and IOL calculations for best postoperative refractive outcomes in cataract patients? So if you remember the older generation formulas or regression formulas, the SRK formula, we used to look only at K readings, corneal power, axial length, and A constant. But now with newer generation formulas, there's a lot of other metrics and parameters that we need to take into account. For example, white-to-white measurements. We now are looking at corneal thickness, anterior chamber depth, lens thickness, of course, our axial length and K readings. And then most formulas, we're actually still estimating the effective lens position. So when we look at all the formulas available to us these days, Vergence formulas are third-generation formulas. All the Barrett formulas are actually Vergence formulas. Ray tracing is the Olsen formula, and artificial intelligence is the Hill RBF. Now we actually are version 3 for the Hill RBF artificial intelligence formula. So we know that in normal eyes, most formulas, they perform really well. And the challenges are now with short eyes and long eyes. So let's talk a little bit about long eyes. So if you're still using a third-generation formula, it's really important to use the Young-Koch adjustment for axial length. We know that the Olsen formula, ray tracing formula, works really well for long eyes, right? So that requires anterior chamber depth and lens thickness. The Barrett, it's very good for high myopes, and especially if you're using minus power lenses. And the Hill RBF. So Hill RBF, because it uses artificial intelligence, is good for short and long eyes, right? So, but I can share what I do in my practice, especially for short eyes. You know, I like to look at different formulas. I usually look at the Barrett and the Hill RBF. Dr. Garg, thank you again for being here with us. And we have a few questions for you.
Sure.
If you want to share with us. How do the third, fourth, and all the newer generation formulas, how are they different in your practice?
Yeah, I think you did a really great job going over this there just a second ago, Karolinne. If we look back to the way formulas used to be, the first generation, we're actually just looking at refraction. Then we looked at regression, and you mentioned third generation formulas or Vergence. And the third generation formulas did really well for us. I mean, if you look at the vast majority of patients were, I think, 80% within half a diopter of target. And again, this goes back to our previous section where this is when you've taken the time to optimize surface, get good repeatable measurements, consistency across your different diagnostic equipment. The newer generation formulas now, we look at ray tracing, and we look at artificial intelligence, and there's some formulas that use multiple different ways to try to give us the best outcomes possible. And by and large, I agree with you. I look at multiple different formulas for pretty much every patient. I don't rely just on one reading. I want to make sure there's an agreement amongst the different formulas that we have. And to me, that gives me a little bit more confidence in choosing a lens power for my patient, especially in eyes that can be more complex.
That is great. And I would like to share a publication with Jack Holliday's group. They look at over 10,000 eyes, right? And it's really nice comparing all the formulas across the board. For normal eyes, all formulas, they work really well. When we look at shallow chambers or the hyperopes, and long eyes is when we really see a trend from one formula. But when you look at the Barrett and, for example, Kane formulas, they work really well across the board. So those are definitely safe formulas, modern formulas, and artificial intelligence. I agree. Thank you. So in what scenario should we use the Young-Koch adjustment? And are you still using the Young-Koch adjustment for long eyes?
Yeah, so the Young-Koch adjustment, is meant for eyes that have an axial length of over 25. And, that seems like really long, but we see patients with 25 axial length and greater pretty often. And so the way there's multiple iterations of this adjustment, but essentially you do the adjustment and then you plug that adjusted axial length back into your formula, and then that spits out the newer adjusted lens power. And so I use it from time to time, but with some of the newer generation formulas, I feel like I'm not dependent on it. So like you mentioned, the Barrett works really well for long eyes and short eyes, and it's readily available on some of our biometers and some of the free IOL calculators that are available online. So to me, I've been using the Barrett predominantly, but if I have a question, I will pull out my calculator and do the Wang-Koch adjustment and see if there's agreement, again, looking at multiple formulas for these patients.
I agree, and I just would like to add that the EVO formula is another good formula for long eyes. So, Professor Garg, I have a 70-year-old male patient with bilateral cataracts and corneal astigmatism. So the topography shows regular astigmatism. When I look at the magnitude and the orientation of astigmatism, when I look at my refraction, keratometry, and biometry, those are all very similar. So which IOL formula would you use to achieve, the best refractive outcomes for this patient?
This is, I wish was a more regular patient for our clinics. Seems like everything was lining up for this patient and exactly what we want. We want agreement between their biometry and their topography. Sometimes I'll get a second topography to look at it. But ideally, you want your magnitude and your axis of astigmatism to be to correlate amongst your different testing, and this patient does. I've found really great outcomes using the Barrett toric calculator, which is available on the ASCRS website. It's also available on the biometer that we use. So for me, that's been really quite good in helping me really target these patients. The one thing that it includes is, again, from Dr. Koch and Dr. Wang, is posterior corneal astigmatism. And I think that's been a real game changer in sort of my outcomes for toric lenses, particularly when looking at against the rule of astigmatism and with the rule of astigmatism. You want to overcorrect against the rule of astigmatism and sort of undercorrect with the rule of astigmatism to compensate for that posterior corneal astigmatism. The Barrett calculator has that compensation already built into it. So to me, that's been my go-to. In patients like this, I'll also use intraoperative aberrometry to help sort of verify what I've calculated already and just looking for agreement. So a double check for me, if you will, prior to really dialing that lens into place on the table.
That is great. Thank you. No, I agree. I think, again, with the rule, we usually undertreat because of the posterior corneal astigmatism and everything we learn. And against the rule, we're a little more aggressive addressing those patients. And I agree, again, if I'm looking at the measurements and the axis, especially the difference is greater than 15 degrees, is when I like to use intraoperative aberrometry.
Yeah, and I'll add one more thing. I'm targeting the lowest residual astigmatism that I can. So depending on the age of the patient and sort of the lens that I'm using, I will oftentimes flip them a little bit to try to get the lowest residual amount of astigmatism rather than undercorrecting and leaving them in their sort of natural axis.
So what new IOL formulas are emerging that show promise of improved accuracy? Anything new coming up?
Yeah, great question. I mean, there's a bunch of new formulas, sort of fringe formulas that are out there. If you look at some of the papers that are out there, they're in certain populations or certain papers, they show various advantages over some of the sort of tried and true formulas. The Barrett formula is still something that I think is relatively new for a lot of surgeons, and they're not using that frequently. You mentioned the Hill RBF formula. There's the EVO formula. There's the Kane formula. So there's multiple formulas out there. Again, my practice is to look at several formulas and look for agreement. And oftentimes I'll look at some of the newer formulas, and then I'll also look at some of the more historical formulas, some of the regular Virgin's formulas. Holiday 1 formula was a great formula for normal eyes. And I'll look for agreement there, because if there's a lot of disagreement, then I try to figure out why that is and try to figure out what lens will give me the most optimal outcome for my patient.
This is great. So most formulas are still estimating that effective lens position. ELP is still, right, like a question mark. And I know there's some studies now trying to use sometimes intraoperative OCT to look at that lens meridian position. And again, in combining all that information with artificial intelligence, I think the future is bright, and we can definitely be more and more precise with our IOL calculations. How do previous refractive surgery in corneal pathologies in cataract patients impact biometry, IOL calculations, and lens selection? So when we see a patient that had refractive surgery, so we know that the changes in the corneal shape, that will change that relationship between the anterior and posterior corneal curvature. And refractive surgery can induce some high-order aberrations. For example, if someone had myopic LASIK, we tend to see increased positive spherical aberration. In post-hyperopic LASIK, it's the opposite. We usually see negative spherical aberration and some coma from decentered ablations. So sometimes, it's a little harder to obtain measurements or reliable measurements, especially highly aberrated corneas or patients that had RK, several cuts and AK cuts. And those patients, post-RK patients, especially sometimes, or high myopes, predicting that final effective lens position can be challenging. And you can still see some refractive surprises, especially post-RK cases, and complications from surgery, dry eyes. And patients' expectations are very high because when they had the LASIK, they had perfect vision. So they are coming in for cataract surgery, and they think they're going to see well for distance and reading. So managing patients' expectations can be challenges in this group of patients post-refractive surgery. So common corneal pathologies that we see, Dr. Garg mentioned before, ocular surface disease, the dry eye or the dry eye masquerades, right? Or that we see on a daily basis, epithelial basement membrane dystrophy, Salzmann's, conjunctival chalasis, or pterygium, or anything that can cause an irregular tear film, blepharitis, or history of keratitis, or history of infectious keratitis, corneal ulcers, neurotrophic corneas. It's a long list, and even corneal dystrophies. So considerations for patients with corneal pathologies. So when you see the patients before surgery, right? So again, we want to get the best possible measurements, corneal topography, tomography, optical biometry, and we want to make sure, the measurements are reliable. It's important to treat those patients before surgery. If it's a dry eye disease, I like to treat 4 weeks, bring the patient back and repeat all the measurements. And you want to educate your patients, right? Sometimes they get a little upset. I'm here for cataract surgery. You need to tell them, no, it's really important to address your condition prior to surgery. If it's epithelial basement membrane, you may need to consider superficial keratectomy or a PTK and bring the patients back. And then when you see those patients after that procedure, then is when you need to make a decision to choose what will be the best IOL option for that patient. So, and then during surgery, there's some intra-op surgical factors, right, that can damage the ocular surface, or drops, or if someone with dry eyes and then they're using drops after surgery, the cornea can decompensate. So all those things that we need to talk to our patients prior to surgery. And then after surgery, you need to always try to maximize your outcomes, treat the dry eye disease, any residual refractive error, address the residual refractive error, and if they eventually develop posterior capsular opacification, you need to consider YAG laser. Professor Garg, thank you again for being here with us. Why we should not use a regular IOL formula for patients post-refractive surgery?
Yeah, this is a very important question. And a lot of it comes down to how we're measuring the cornea with our traditional measuring devices. So typically, a biometer is going to measure the paracentral cornea and then extrapolate the central corneal power. And in someone who's had myopic LASIK, what ends up happening is their cornea is flatter than what is actually being extrapolated. So you end up with a higher corneal power, which means you're going to end up with a lower powered lens, which means you're going to end up with a hyperopic error. And the exact opposite is true of post-hyperopic LASIK. The other thing is, many of our formulas, the index of refraction is estimated based on that anterior corneal curvature. And we know that the relationship between the anterior and posterior cornea is different in post-myopic LASIK and post-hyperopic LASIK. And that those relationships are then oftentimes how these formulas predict the ELP. And we know that ELP, or effective lens position, is a really important factor in how someone ends up post-surgery. And so these are just some of the reasons why you can't just use normal IOL calculations. And then, even if you use a fudge factor, which most people have gone away from, you can still be off in a large percentage of patients. So we're lucky that we have other tools available to us to help these patients.
Dr. Garg, I have a 62-year-old female patient who had LASIK 20 years ago. What is the best IOL formula to use, and what type of IOL would you consider for this patient, and why?
This is a loaded question, Dr. Rocha. There's a lot here to unpack. So if you look at the question, 62-year-old female who had LASIK 20 years ago. So LASIK 20 years ago was not quite as precise as LASIK is now. So you have to look to see how much LASIK they had, what the pattern looks like. Was it myopic or hyperopic? An important question for these patients is, were they happy with their vision post-LASIK? If they were never happy with their vision post-LASIK, you have to be really careful to look for irregular astigmatism, or as you mentioned earlier, decentered ablation. With respect to which formula to use, I really rely on the ASCRS website, and I plug in the information that I have available on the patient and look to see what the different formulas will predict. If I had to pick one formula, recently I found very good outcomes with using the Barrett TrueK formula for these patients. I feel like that's been quite accurate in patients that are at least with post-myopic LASIK. And then when you look at LASIK, you mentioned spherical aberration and induction spherical aberration for the myopic patient, and post-hyperopic patients have more negative spherical aberration. So it really depends on the type of LASIK that they had, the success of the LASIK, what the corneal optics look like to determine the type of lens. For post-hyperopic LASIK patients, I frequently put in more traditional lenses that have a positive spherical aberration with them to try to offset their negative spherical aberration. And then for patients who have myopic LASIK, either I'm putting a zero spherical aberration lens or a negative spherical aberration correcting lens for them. And on occasion, I'll even put in a diffractive EDOF lens if they had successful LASIK, myopic LASIK that was low in magnitude. If someone had a lot of LASIK, I worry about all the higher order aberrations that were induced.
What is the best formula for calculating the IOL power in hyperopic patients that had refractive surgery, post-hyperopic LASIK?
Yeah. So, this answer is very similar to the last question. Post-hyperopic patients, hyperopic LASIK patients, it depends on, again, how much hyperopic LASIK they had, how long ago the treatment was. We find that in a lot of these patients, especially if they had low amounts of hyperopic LASIK, they sort of regress back to almost normal, and there's not a lot of compensation needed. I do look at spherical aberration in these patients, and this is where I'm really looking at the centration of the treatment. It's not uncommon for hyperopic treatments to be off-center, and that has big implications, like you mentioned, in coma and irregular astigmatism and just overall corneal optics. And this is, again, another situation where I do look at the ASCRS website and I look at multiple formulas and try to, look between the different formulas for some agreement.
Dr. Garg, would you approach optical biometry in which IOL would you consider in patients with keratoconus? So this is another hard question for you today.
Yeah, thanks for that. Keratoconus patients they come in, obviously different severity. And patients with mild keratoconus, sort of Ks under 48, just say, sort of in the mild category, that have somewhat regular astigmatism, especially centrally, those are patients where you don't really need to do a lot of adjustment for them. Once you get into the moderate grade of keratoconus, sort of 48 to 52 on the keratometry, or severe greater than 52, this is where you get into more trouble. With respect to toric lenses and keratoconic patients, what I'm looking for is if they were successful patients, meaning they had good vision with glasses prior to development of their cataract, they may be a reasonable candidate for a toric lens. If they were always contact lens dependent, particularly a hard contact lens, I steer away from any kind of toric lens because I want to leave them the option to have a contact lens afterwards. The really difficult ones are the really steep patients because oftentimes the predicted lens power is very, very low, which often leads to post-operative hyperopia. And, I think if you're going to be off with your refractive power in patients, I think residual myopia is much more tolerated than residual hyperopia. So there was an interesting paper which showed that in patients with really steep corneas, perhaps it's best to use not the measured K, but use an average K of, I think it was 43.25, and still aim a little myopic. And with those patients, they found that they were closer to emmetropia and maybe ended up a little bit myopic rather than a hyperopic miss. So, again, keratoconics depends on the regularity of their eye, how steep their eyes are, their dependence on glasses versus a contact lens, and really what their goals are with respect to which lens to use and which IOL to use. But in general, if they're really, really severe, I'm sticking to a monofocal lens, trying to leave them a little bit myopic because I want to be able to get them back into a contact lens. And I think a myopic fit on a contact lens is going to be better than a hyperopic fit for a contact lens.
Thank you so much, Dr. Garg. This was excellent. Thank you for joining us today.
Thank you, Dr. Rocha.